guys, I'm Carla.
I'm Shelly. We're not the Smiley twins.
I loved it. I just love it. It's so stupid, but at the same time, like, I just think it's great. This is another episode of Not Just Lip Service. We have some good ones coming up. We have a good plan for these. I think they're coming out bi-weekly now so that we don't feel so, all you people doing podcasts every week, kudos to you, because my goodness gracious above. It's just
more.
Yeah, it's just difficult to sit down and do it unless you're, I don't know, it's just hard. So here with Shelly Proctor today. She's our Director of Quality and Compliance, and she came on with us right at the end of May, and we've done a podcast with her before, I think, in the past, but we have her back because there's just so much good stuff. It's good. The more we dig in and dive in, the more we find the things that are parallel to the hospital setting. Me and Shelly worked together in the hospital setting for a few years, and she was the Vice President of Quality. I'm stealing her thunder here, and Shelly's actually not a nurse. And I bring that up because I think it's such an important asset of hers that she has the eyes of somebody who is not clinical by nature, even though her whole history has been in healthcare, because it just brings she just challenged me all the time when I worked with her about a different viewpoint, a viewpoint from the person who is the lay person, a viewpoint, even though she had the knowledge, like she just always looks at things differently. So anyways, I'll stop talking about her now, but we're going to talk today about the importance of clinical documentation, how it parallels with the hospital and how it's really no different. We have some fun stories from both our past and currently about how documentation has not had to save us yet in aesthetics, but how it did in the hospital, but how tying it into how many board complaints have we dealt with? Several, a good handful.
Yeah.
Where people call and make anonymous complaints. We're going to get into some of those as detailed as we can without too much detail, and show how, had they asked for documentation, which at this point we haven't had that inquiry yet, but it's coming. It's only a matter of time before they ask, and they have a right to see it, and we have to provide XYD documentation. Did we have to, on our one incident on the east side of the state, did we have to, our original one? Yeah. She asked a ton of questions about timelines and time, all kinds of stuff, but we don't think we ever, So I was talking to our Chief Legal Officer, Courtney, who's sitting here. We didn't have to actually turn over any actual documentation, but boy, she asked all the things, and we interviewed for over an hour about the different aspects and timeline and what was documented, et cetera. So we did have to send over proof of different trainings, which in my mind is no different than clinical documentation, proof of XYZ, just a variety of different things that are employee documentation, clinical documentation. I mean, it all kind of falls into the same thing.
Yeah, it's like you've got your client-patient documentation. That's to help protect the patient, also to help protect you as a clinician, but then all of, like you were saying, the training,
right,
and, keep licensures, all of that, that's also to protect our client patients as well as our injectors.
Yeah,
so you really can't delineate that, like, this is for just for our clinicians and this is just for our clients. It's really overall.
That's I don't even know that we intended to go into that, but I'm going to deviate on that pathway just slightly, because a lot of people who are listening are new to aesthetics, because we're all kind of new to aesthetics, and what it all comes down to it. Do you ask yourself, do you have, those training certificates that we would get, like in the hospital, we're like, another cute little, you completed. And it's like, yay, go HealthStream. And we all hated it. But all of those, when it came down to it, if your, hand was over the fire, are all things that were going to save you, because they're all, whether you paid attention or not, they were all ways of, showing that you had additional training or whatever the case was. So aesthetics is no different. I mean,
right. It's about having the documentation to prove that you as a clinician are competent to provide the services that you're providing. Whether that's a surgeon doing surgery in a hospital, they have to go through their an entire quality control process.
Right.
Or it's a nurse who's starting a mobile med spa.
Yeah.
You want to make sure that you have documentation showing that you are competent to perform the services you're doing, especially if it came to a board inquiry or anything else. And it's also just asserting the fact that to showing, you're managing yourself up. Look at what I have been trained. I am capable.
Yep.
And it also, you can manage yourself up to your clients as well.
Yeah.
I've had all of this training or additional training.
Yeah.
We used to say that all the time in the hospital. I walk into the room, and if Carla walks in with me, I'll be like, oh, for instance, I'm your physical therapist, but I had your speech therapist, Carla, here, and Carla has 20 years experience.
Yep, that was literally like the script. I mean,
it's like, how do we manage ourselves up? And it's showing, it's not bragging, it's showing what you're competent of, but then also helping your patients and clients feel at ease too.
And for the aesthetics world, especially in light of the way sometimes aesthetics gets almost like a salesy pitch to it, like we are all about that it's medicine, that it's prescription, that it's all these things. So it's not silly, to your point, to manage yourself up, because we are battling even more than a hospital. An inherent lack of mistrust. Whereas in a hospital, people typically come and have a much bigger level of trust of either physicians or nurses. We don't really have that luxury, like, at all. So covering your wall with all your, AMI certificates from all the different trainings you did, like, why wouldn't you? Like, look, because it's only going to credential yourself and make them see you as more of a clinician, as more medical. That's actually a great point. I love that. And then and then when you get those certificates, I mean, here it is, download, drop it in a folder on your computer. I mean, it doesn't have to be something fancy. It is so simple to keep up with that stuff. And then I have all of our stuff. I'm sure we both do. Financially, by example. I mean, there is a folder that I just keep updated every month, because goodness only knows I'm going to have to be sending, whether it's a bank statement or something else, monthly financials, whatever it is. So just taking the literal 2 or 3 minutes it takes me each month to update that makes it so easy for me to be like, yep, here's a zip file, boom, here's everything you could ever want. It's education and stuff like that is really important to do. So keeping up with your stuff. Okay, so clinical documentation. Talk to us, Shelley, about why do you think that we struggle so much with it when it is literally what's going to save us when it comes down to it?
So before we get into that, because I know when you were a little girl dreaming of being a nurse one day, you were doing it because you wanted to sit at your computer and document patient charts.
Well, absolutely.
Right. Everybody's dream is documentation.
Okay, so I like where you're headed with this already. Go ahead.
But it's just, it's one of those required things. And it's not just like, oh, I got to do it because somebody in the quality department says I got to do it. No, it's to protect your clients, and it's to protect yourself. So there's the protection aspect, right?
Yeah.
And that's kind of jumping to the, like, what if something bad happens, but tying into what we were just talking about. But it's also, I always said, I'm like, you don't document in the chart necessarily to cover your butt. You're documenting in the chart to provide continuity of care, right? Because what if someone else comes along, like in the hospital, you're not documenting to say, this is what I did. It's like, what about the nurse that comes on the next shift?
Right.
3 shifts from
right.
now? What's important to notate about your client? So it's continuity of care.
That's a good.
Is one of them, because your clients are going to come back in 3 months, 4 months, 6 months, however it may be. And you think you're going to remember everything about that client. And you may have your standardized documentation. We'll talk a little bit more about documentation improvement and how you can have, if you're looking to improve your document, if that documentation, that's what keeps you up at night. It's like, how can I do a better job? But where you want to notate specifically, what about when I treated Carla makes her unique?
Yeah.
Because you can have your templates and kind of your
doc phrases
your doc phrases, and this is what I always document. I reviewed the consent, answered any questions.
Because a lot of people are normal, right? Yeah, the bell curve covers like 95% of people. So that's okay to have some quick hitters that are basic.
Sure.
Yeah.
But then that charting by exception, it's always like, what is it about that client? And you may not have to do it on everyone, but if there's anything just out of the ordinary, you're like, that's odd.
Yeah.
Make a note of it in the chart, and do that in an objective way. We're not providing opinions. It's like very factually, what is it about that page? It could be that it's like, I've had some tingling on, my left jaw.
Yeah.
Off and on for, 3 months, but really nothing. It doesn't really bother me. I haven't seen anyone about it.
Yeah.
I might just want to include that in your note.
Yeah.
Just because in 4 months, if they come back, you may want to reference it, or, from a risk exposure perspective, you've gathered that information.
Yeah.
And then what are you doing about it? It could just be that passing comment, or it might be something that you want to let, if you're working with like a mid-level, let them know about for further exploration.
I think all too often, Shelly is in the perfect role, or was in the hospital, and one that I fully respected. It really didn't until I was a leader. Because from a nursing perspective, I think quality, sometimes, we've talked about this many times, quality can just come down and feel like such a, well, you got to do this, 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 and this, instead of, it just feels like, it feels like
punitive.
Yeah, that's a good way to put it. But Shelly's role was so interesting, and I didn't realize it until I was on the other side as a leader, that you do have to protect both yourself, and you want the continuity of care for the client, because that's what's right. But then the other side of that is protecting yourself. It is so that, and it doesn't always mean because the client's going to come after you. It's more protecting yourself so that, to your point, 3 months from now, when something does happen, you're like, oh yeah, they mentioned that tingling in the jaw, or you make the recommendation, or whatever the case is. So you are covering yourself, and that is also providing that continuity of care. And your role as a quality leader is literally the in-between. It's trying to figure out, how do you protect the clinician, the leader, the whatever, of whatever entity, while also providing the best clinical outcomes for the patient and the continuity of care. And it's an interesting balance, but you've just made the best like examples of objectivity in charting. So it's not a, well, Mrs. Smith was kind of a jerk when she came in today. She wasn't very nice, and blah. Or is it Miss Smith asked, about 15 different questions about lip filler. I became uncomfortable and recommended that she might see another provider. As opposed to, what I just said. Like, it's not about, it's why you did X, Y, Z. And then she wanted, whatever the case is, it's being objective. And I think that that's a really, that also helps, and correct me if I'm wrong, bring down the amount of words.
Yes.
Like, when you just take out the opinions.
Oh, absolutely. And you can say a lot and not many words, speaking on prior experience, looking at going back kind of the hospital days. There was literally a nurse's note that helped a case that really, it was like, well, no one checked on this patient for 6 hours, the family's alleging, for instance. And, a quick nurse's note with just a few words, patient observed resting, no complaints.
Yeah. It's like,
I don't even know how many words that is, 6, 7, and it doesn't take very long, but it shows, like, I laid eyes on that patient. They weren't in any distress. They had no questions.
Yeah.
So it doesn't always need to be this novel that needs to be written in this huge thing.
Right.
And it's the same thing, I'd say, in aesthetics. It can just be something short and sweet, and it may just be enough that, 3 months from now, when you see that client again, it just triggers your memory. Be like, oh yeah, I remember that.
Yeah, or like patient, and so in aesthetics, obviously we're not dealing with like life and death, and people are generally not sick, but walking that over as something as simple as patient, says every time she gets Botox, she feels like her right eyelid droops. And so noting that in the chart, so then when she comes back in a month and is like, well, you made my eyelid droop. It's like, no, you said every time this happens, we were very careful. I informed the client that I don't droop eyelids, but I put units here and here. And if you feel that in the past, it's possible you're going to feel it again. Like, you're just protected if anything were to go beyond. Now, we don't have a super litigious environment in injectables and aesthetics in terms of basic Botox, basic lips, things like that. However, with the way medicine works, it will certainly head that direction. As the more people get it, the more errors can happen, or just basic complications like a VO. Like, those are gonna happen. It's not a, like Mary always says, it's not an if, it's just a when. So it's how you document the response. So talk about a little about that, because aesthetics is we see you and you leave. Yeah. And it's not like the hospital where there's any of that stuff. So talk about how if something happens in the future or whatever the case is, how important it is to follow up on that.
Yeah. Great examples you gave there. So important just at any step. So say, a patient had a mild complication like Carla had just explained. If you call that patient in 2 hours, make a note of it. Yeah. If you check in with them via text in 2 days, just putting that in that client's record, that objective listing, reached out to client over the phone, swelling's gone down, whatever the case may be, answered all questions, patient's feeling good, instructed to call with any worsening concerns, or to
add the
seek
picture
treatment at an ER.
If they send you a picture, add it to the chart. I mean,
don't let all of that just live on however you're communicating.
Right.
That needs to go in the client's record. Again, it's a protection thing, but it's also just that record, just like in any part of healthcare, that's that legal medical record for that client. So
well, and it's also continuity, because if she calls and I answer the phone, if I don't know, I talked to somebody yesterday, it's like, okay, and you know how it is. Well, what did they say? They just don't know. They're in the midst of, if it's any kind of complication, that's the difference, I think, too, in aesthetics. Any complication in aesthetics is heightened by the fact that it's a lot of times your face. Yeah. So the stress, the freak out mode, I mean, it is intense. We've had a couple different VOs, all handled beautifully, but the client is freaking out and they think their nose is going to fall off. I mean, they are certain of it. Their lips are going to fall off, or they have terrible, whatever it is, bruising, whatever the case is, it's on your face. So we have to be sensitive to that, and also realize that level of stress puts emotions out of check. Memories are different, angers can rise, like all types of stuff. Clients can go from being very, very happy to being very stressed in a short period of time. So documentation is critical.
Yeah, absolutely.
Yeah. Okay, so let's roll into some of our how documentation, and again, we don't have any examples where we've had to turn over documentation, but let's talk a little bit about the board, because the fear, one of me and Mary's biggest pet peeves in nursing, and I think we may have discussed this in the past, is the statement of, well, it's my license. And I'm like, that is true. But and it's true 100%. And I don't mind that until it is related to the fact that you could lose it like in the drop of a hat. I'm like, okay, guys, like the board is not out to get you. Yeah. Like no one is out to like chase you down. Like if there's a lot there's, as we saw with the nurse case.
I was just going to say the nurse at Vanderbilt and the criminal charges, which is really like historic. It has not happened really.
No, and it hasn't happened since.
Criminal charges. Yeah. And that's just, and then you could get me going. I can do a whole other episode on culture of safety and all of that stuff too. So, but that completely undermines the culture of safety and self-reporting and all of that.
Right.
But you were talking about, it is your license.
Right. Well, just that it's not as easy as, someone calls the board and complains about you and says you did XYZ and your license is now at risk. It's like, guys, okay, even if you had no documentation, and you're a nurse and you did Botox, that doesn't mean they're just going to take your license. Like I just can't stand that mentality with nursing. And I think it makes us, to your point, degrades the culture of safety, but then I will say, and we could have a whole podcast on what happened in, I think it was 2017. There is a whole negligence side of it. If you do get a VO in a lip and they call you back in an hour and they're like, man, it's just turning black and blue, it's starting to hurt me. And you're like, yeah, just watch it. And then they call you 5 times in the next 24 hours and you never answer. That's called negligence. Yes. Like there is a difference between, care and just being either wrong or making a mistake, which happens, and just straight negligence. So,
and there is cases where it's like everyone knows in healthcare, you can do absolutely follow all the evidence-based protocols, do everything right. And unfortunately, there can still be bad outcomes. It's just
that happens.
The nature of healthcare. But it's not necessarily, like, I think what you were getting at was, it's not necessarily, the board's not coming at you like, I'm going to get you and nail you to the wall.
Right.
Like, that's not the first inclination. So if you've been in a hospital and gone through like a joint commission survey, they can feel like, I'm, talking to those surveyors, you're like, oh my gosh, I don't want to say the wrong thing.
Yeah, you're going to get me.
But they also are there to help protect you and the facility. It's the same thing with the board. It's not about, I'm going to get you, and ruin you and take your license.
They're all
It's like, how can I help you and be an advocate? Yep. Do you have the tools that you need? And coming at it from a way of like, help me understand what happened.
Yeah. Where did I go wrong? Right. If I even went wrong. So not to cut off that conversation, but in our experience with the several that we've had, we've talked to, I don't know, 4 or 5 different investigators with different boards. They're all calling, and honestly, like in defense of the nurse. Like they ask all the questions, and if you come across it with that type of mentality that you are have a defense, then it can feel like they're poking holes and you should put yourself on the defensive. When in reality, poking holes, honestly, trying to get you to even see what all you did do and how you did do everything right. Because a lot of what we do is second nature. So you did do a lot of things right. I'm just trying to get you to say what it is that you did do right, so I can protect you and be like, yeah, this is no big deal. Because do you guys know how many anonymous complaints, as soon as someone gets pissed off at anybody, a nurse or a doctor, bam, I'm going to call the board. It's like, okay, call the board. Like,
it's just that.
But we perpetuate that environment by being like, what's my license? And I'm like, yeah, you're not wrong, but like.
Well, and you did a lot of work to get your license.
Yeah.
And it's a lot to keep, you have to do continuing education to keep up with it. But it is, in those questions that may be asked, it's really from like a place most of the time of understanding. And because like whether it's a surveyor or someone that works for the board of nursing, like they can't like be seen as prompting you or like giving you the answers. So how they get the information is really just a series of questions. And it's it feels like a lot of prodding, but to your point, in most cases it's to like, I'm trying to help you show how competent you are, what you have done.
Because we call it crocodile brain. Like you are seeing it from
it's like
the expert.
Theory,
yes.
right?
Yes, exactly. You're seeing it from the expert's lens, and so you don't even understand how far ahead of you are from the average person. So you don't even know to step back and talk about all the things that you actually did. And I will note here that one of the reasons me and Shelly can talk about this openly, and I have such a strong opinion, is because I was a surveyor, and Shelly was a VPQ in a hospital, and that was one of her main roles, is dealing with the Joint Commission and dealing with CMS and Medicare and Medicaid services and all that type of stuff to make sure every single rule that is had, it's because there's a reason and a why behind every single rule. There was rarely ever a rule or a standard or whatever from the Joint Commission, whatever you want to call it, or statute from whoever it was, that wasn't backed by an example or many examples or evidence as to why something had happened. I mean, it is very evidence driven. It is very, very much a culture of safety. It's trying to get you to tell things. Self-reporting, like, does it come with a lot of work after? But Lord help, if something happened and somebody cut off the wrong leg in a surgery, there's a lot of dang work that needs to happen, because a lot of things went wrong.
And what can you learn from it?
Yes,
like, it's
how do we be better?
A place of like continuous improvement. So I think that takes a little bit, like, it's not the natural inclination.
Right.
Think of like a quality improvement process. It naturally, like, your gut instinct is gotcha.
I'm in trouble.
Just like if I ever was at work and my boss like, hey, do you have a minute? My immediate reaction is always like,
I hope Jesse's listening to this call. Every time I'm like, Jesse, come here. She's like, I'm like, okay, stop it.
What did I do? So, if you lead people, I'd always be like, hey, do you have a minute? Nothing urgent, nothing bad. But it's similar to that. Our natural reaction is, oh my goodness, the board's calling me. What did I do
Defense
wrong?
is up.
That's natural. We're all human. That's just natural instinct. But, trying to, and going through, adverse events, investigations, and it's always like, how do we learn? How do we make it better? And it's always very process focused and probably applies to aesthetics as well. It's like, what can you do from a process perspective to improve safety and quality?
So a good example of some of the board situations we've had, this is what a couple of them have actually been about, is like knowing who like the medical director is, by example. We talk about that a lot. We're very proud of our medical directors. They're very involved in our company. And we learned from the first one what we needed to do, or the second one, what we needed to do. And we've had multiple since that literally when the call was made, I will admit I don't answer typically on the first call anybody, because a lot of times I'm doing like I have 3 calls and I'm recording a podcast. So I'm the same way, because it's natural. You get the voicemail that's like, this is the Tennessee Department or whoever Department of Health and investigate blah, blah, blah. yada, 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 whatever they say, give me a call back. So I'm like, okay, this is, you don't tell you names or anything like that. Again, it's the level of confidentiality that they have to follow that makes us and our defenses raise, which isn't fair because it's like, I'm not spewing something over a voicemail. Don't even know if I have the right number.
Yeah.
So I'm not going to spew some nurse's name. But for us, it's like, oh, she won't even, it's like, I don't even know what's going on. That's just try to think of the other side of things when you get to that phone call. But then when I called her back, it was fantastic. This has happened twice. Because of what we'd done in the prior calls and the things that we had changed, she had literally already gotten all of the information she needed without even speaking to me. It was like, I don't think I need anything else. And that was the end of that. And it's happened twice. So instead of looking at it as, and again, some of it's a maturity thing in terms of if you don't have experience with it, it's really difficult to change your mindset. So me and Shelley certainly are cheating the system by having the experience, but by looking at it from what can I do better, or why is this important, or why is that law what it is? Why do people need to know who my medical director is? Yeah. And when you say it that way, a nurse or any injector who's listening to this is like, well, I mean, obviously, and it's like, okay, so what's the problem if the board is, someone called and complained and said they didn't know, and then now they're asking you about it? All of a sudden it's a problem. It's like, well, no, they're just trying to help bridge the gap between consumer and you, and not necessarily trying to come after you. So,
and that's like in Tennessee, why you gotta have, we in all our states have who the medical director is on the door,
and everything,
locations that they're board certified and what their specialty is. It's just to help in that situation. Just it's information. So a lot of concerns, complaints. It's just that communication gap.
Yeah, and then there's just people who are out there making anonymous complaints because they're just jerks, and we know that, and in the same way in the hospital. No matter what you do, Yeah. Okay. Well, any other comments or?
Yeah, I think just so what can you do now in your practice?
Okay, great.
From a documentation. So we talked about why it was important. 2 real ways you can look at improving is just try to have that standardization. So if you're a Smiley injector, we've got dot phrases, which are just those short macros where I can put it in and it explains, that standard language. I went over the consents with my client, answered any questions, all of that. So standardize your documentation, also add in those client-specific scenarios that we talked about, and then regular review of your documentation or having someone review it. So I've talked about it on another podcast, and also we have a document on Patreon of a sample. If I want to start auditing my charts, where do I start? So we've got a sample form out there on Patreon if you wanted to look at it and tweak it to your needs. But just anytime you're kind of thinking quality improvement, I think keyword to me is objective. Define what do you want to look at and be consistent in it. So trying to keep the emotions out of it. If I want to know all the consents are complete and I've got my treatment markings, my before and after videos, and then what those components of the notes are, and just going through it and just trying to be I don't want to say your own worst critic, but just that's how you improve, right? Looking at it if someone else was looking at that, do I have all the information if I have never seen that client before? And then, it doesn't have to be, you don't have to look at 100 charts. You can look at a handful. But define what that is. And then you'll probably glean 1 or 2 things oh, maybe I need to improve my standardized documentation around, follow-up treatment plans. People are having questions about that I can add that in there. So
I love that. Those are
sorts of things.
Super practical. And what Shelley just described is you just started your own quality department for your business. I mean, that is the baseline, and that goes a long way. And we have talked about and given our QC information to the board. So when they asked, we were able to explain exactly the policy for what we did, how we did it, how we monitored XYZ, and that is a quality department. So you can say, yes, I have a QC. We use QC all the time. I have QC process, quality control process, or quality improvement process, or QI, whatever word you want to say. And this is what it is, and it can be a single-page document. And then ideally, your medical director signs off on that, which again, any medical director who has an issue with you doing your own audits and quality control would be a surprising person to me. So you have then that also helps them in their role, because every physician, every medical director in any state has a due diligence of quality control of whatever they're overseeing. So you're just making that more robust. I mean, you literally just started a quality department within your business. So I love those tips, and they're practical. I'm obsessed with standardization. So we are very much on the same page as with that. And then, like Shelly mentioned, because when she was talking, I'm like, oh yeah, that's a good idea. And then it's on Patreon. She already made one. Of course she did. So www.patreon.com/SmileyAesthetics. That example for getting started. We use Aesthetic Record. We love Aesthetic Record. We're very open about that. So a lot of the pieces are built off of what our charting is, but Aesthetic Record has done a good job of having the pieces that are required from a compliance perspective. So that's why one of the reasons we're a fan of them, and why that checklist will make sense for almost anybody. Yep. So if there's something on there, GFE, and you like, what is that? There's a lot to unpack there. And so it should trigger some things that I think, to Shelly's point, might have you make you have questions, or maybe you document too much. And there's the over documentation problem too. Real quick before we jump off, speak to over documentation, because Lord knows in the hospital sometimes, and that's where I think nurses get twisted and mad. But it's like, but listen, look at what you said. Like, it's just a lot
of over documentation comes. It's more subjective in nature.
It is.
It's like
Dr. Smith came in and screamed at the patient, and then smacked her in the face. And it's like, wait a second.
Patient Carla had a terrible attitude and told me she didn't like my hair, and then questioned if I really even knew what I was doing. And so I told her that she had no idea what my It ends up being, it's not your diary entry. I think the over documentation can be like,
that's it.
My
feelings.
Or that subjective stuff, that's stuff maybe that goes in like an incident report. That's a whole other conversation.
Yes.
But it's like those things, that's maybe something that I go to Carla, who's my one up, and be like, oh my gosh, this is what just happened.
Yeah.
You know, or you report it to your medical director and just be like, this client was super inflammatory and I just have a bad feeling about it.
Yeah.
The place, there's a way you communicate that, just not necessarily in the client's chart.
Right. And I think that incident reports, to her point, it's protected versus unprotected stuff that's discoverable. We could get into a whole nother world of like that type of stuff. And I think that sometimes, again, I call it out because I was on that side of, seeing some of those things, well, can I say it or not? Like that's what leads into also or adds to the punitive feeling. Mm-hmm. But again, Shelly's a perfect example. You're playing both sides of it because you want to protect. If you're like, my CNO told me that I wasn't allowed to come in this room more than once every 2 hours. It's like, that's just not, what we're putting in a chart. Like, and I think it's for obvious reasons. Like, that's just a different realm. Or my medical director told me it was okay as long as the person wasn't too drunk. It's like, I mean, if you want to put that stuff in there, I think
just be prepared that you have to speak to it someday.
Yes, that's a good point. Just be prepared that you will have to speak to, and you believed him, or you said that was okay.
It's like the whole thing, don't do anything you won't want your grandma to read about in the newspaper.
Yeah.
It's that sort of thing.
Yeah.
Like, don't document something that you don't want to be prepared to talk about later.
Patient agitated goes a long way versus... what Shelly said earlier. Yes. Yeah. Or patient, seems to be under the influence. It goes a long way versus, a lot of other words. So if you want any other tips about that, please reach out. Shelly or myself, again, a lot of experience looking at a lot of charts and seeing the greatest things in charts. I mean, just some really fantastic things that are just awesome. And a lot of it is nurses trying to protect themselves. Mm-hmm. And I think that we need to continue to try to break down the barrier of the punitive feeling between our regulatory bodies and our actual care, because they're really aligned. Mm-hmm. It is so difficult to break that down. I mean, the animosity I felt as a surveyor, and the animosity you've talked about you felt as on the team. I mean, I work for the same team. I'm on your side. Yeah. It's crazy. Like, but what are we doing? Again, we'll start the ball. What are we doing as those leaders to learn from what we're doing that's making nurses feel that way?
Yeah, exactly.
Yeah.
And
medical
I think our Carla and I and everyone here at Smiley Mindset we have is just number one thing, being approachable.
Yeah.
It's like you want people to feel like they can speak up if they have concerns.
Yeah.
It's a whole culture of safety premise. But it really is like you want people to be able to speak up if they have concerns.
Yes.
And it's always, and that speaks to transparency that leads to improvement.
Yeah.
So that's kind of the whole thing. It's like being transparent so that we can improve the care for our clients.
Yep.
And then improve how we're supporting our clinicians.
Right.
Yeah.
Okay, we'll wrap this up. As always, you can find the podcast. Mary does this all the time, so I'm real bad at this part. Podcast is on everywhere that it's streaming. You can find things that are streaming. So Apple and
all the places.
Spotify, I think,
Everywhere.
I don't know, all the places there you can find Amazon, of course, the YouTube. If you found anything useful at all, if there's any point in this podcast where you're like, oh yeah, please share it, subscribe, share it with another aesthetics professional. We're just trying to improve the field and, support community and collaboration so that we all can learn and make our field, elevate our field more and more than it has been in the past. Like Shelley mentioned, we have a ton on Patreon now. I mean, it's kind of gross, to be honest. Like, it's like giving away the farm. I mean, it is. So www.patreon.com/smileyesthetics. There's a lot of free stuff. There's a lot of stuff that you can be a member and get access to different, all kinds of stuff, legal, quality, business, just different things that we think give a lot of value. And then, what else? I think that's it.
All the other socials.
All the other things. Yeah. Whatever else Mary says on these podcasts. But thank you so much for listening, and we will be back with another episode soon.
Yep. Bye.